Hello, we are from group 1A-2. I am the team leader, Mary Shakira binti Al-Jabita.
My name is Akila binti Azharan.
My name is Muhammad Azrin bin Suhaimi.
My name is Nursuhada Arifah binti Yusuf.
My name is Nur Anisiwani binti Muhammad Sandi.
We are doing a case study in the oncology ward.
Tumour is an abnormal mass of tissue that results when cells divide more than they should or do not die when they should. Germ-cell tumor, on the other hand, is a type of tumor that is sourced from the cells that produces sperm or the ovum, which are found in the testicles and ovaries. Germ-cell tumor is rare, but it can be cured with medical treatment. We chose this case study because we aim to understand the disease process, investigations, and management of germ-cell tumor, which is affecting our patient. We also seek to understand the side effects and management of chemotherapy. What is particularly challenging about the diagnosis is that the patient was firstly diagnosed with left pleural effusion. A thoracic CT scan was conducted and it shows a tumor on his lungs. Then, they performed ultrasound on the testis and it shows bilateral testicular microlithiasis, which is indicative of germ-cell tumor. The prognosis of the cancer is intermediate to poor, as his serum AFP and HCG are highly elevated. The management was rather challenging, as the patient had experienced allergic reaction after the infusion of etoposide. Blood investigations during chemotherapy also revealed the patient to have hyperkalemia due to a side effect called tumor lysis syndrome. This shows us the multiple challenges of chemotherapy. A similar case was reported in 2017, in which a 35-year-old male was firstly diagnosed with left pleural effusion and suspected to have tuberculosis. However, he was misdiagnosed as the anti-tubercular treatment does not improve his condition. An investigation was conducted and it results in the discovery of yolk sac tumor on his lungs. Ultrasound on his testis exhibit a mass on his left testis. Moreover, serum lactase dehydrogenase (LDH) and alpha fetoprotein (AFP) was highly elevated. He is diagnosed with non-seminomatous germ-cell tumor with mediastinal metastasis.
Due to privacy reasons, we decided to name our client as Mr. K. Mr. K is a 23-year-old male Christian Kayan. He previously has no known medical illnesses. However, he has family history of cancer, whereby both his grandfather and grandmother died of cancer. He started smoking when he was 20 with 1 to 2 sticks per day. He also drinks alcohol occasionally, especially during festive season. The reason he was admitted to MRTU SGH is because he was a referred case from Hospital Bintulu. His diagnosis is germ-cell tumor. When he was in Hospital Bintulu, he came into the emergency department with complaints of shortness of breath, productive cough with whitish sputum, and fever on and off for 2 weeks. He also claimed that he had lost his weight of 4 kg for the past 1 month, even though he did not have loss of appetite. A brief assessment was done on him during our interview session. The findings are as followed. In general, patient's overall condition was normal. However, he did have skin lesions over his abdomen, but he said that it did not cause him any harm. His posture and gait were normal, and there was no edema on his legs. His hair was thinning due to the side effects of chemotherapy. His eyes were equal and reactive to light. He claimed that he has mild hearing loss over his right ear, but his left ear is good. His mouth and lips were dry. During inspection, he had no chest pain or shortness of breath, but he stated that he did feel chest tightness sometimes and that the aggravating factor is unknown. His upper and lower limbs were both normal. His range of motion, reflexes, and movement were also normal. There was no nail clubbing and his capillary refill was less than 2 seconds. His abdomen was of normal appearance except for the skin lesions seen around his abdomen. His sensory was also normal. As for the clinical investigations, we compare the biochemistry reports received on 17 November with 18 November. We can observe obvious changes in the electrolytes and the urea creatinine levels. The electrolyte imbalance is a result of the side effects of chemotherapy. He developed hyperkalemia on 18 November, which can be proven by his potassium level of 5.7 millimole per liter. The creatinine level decreases because IV mesna was given together with the other chemo drugs in his chemo regime in order to reduce the risk of nephrotoxicity. Other clinical investigations that have been done in Hospital Bintulu as well as SGH are as followed. His chest X-ray on 8 November showed right pleural effusion. CT thorax on 8 November showed that he had suspicious huge mass that caused subtotal collapse of his right lung. Urine pregnancy tests showed positive results. Alpha ferroprotein, AFP, and beta subunit human chorionic gonadotrophin, beta HCG results were highly raised. Ultrasonography, USG tests showed bilateral testicular microlithiasis.
Hello, I am Nur Syuhada Arifah and I present on a disease process. This patient's diagnosis is germ-cell tumor, yolk sac tumor, and mixed tumor. These tumors grow from a reproductive cell and might be cancerous or non-cancerous. Most germ-cell tumors which are cancerous appear to be testicular cancer or ovarian cancer. But some germ-cell tumor can grow at other parts of the body, such as abdomen, brain, and chest. It is rare to find extragonadal germ-cell tumors. Germ-cell tumors tend to respond to medical management positively and can be cured even though diagnosed at a later stage. Yolk sac tumor is a type of malignant tumor occurs in the yolk sac of the embryo, which later become ovaries or testes, but sometimes occur at brain or chest too, whereas mixed tumor is made up of at least two different types of germ-cell tumor, which include choriocarcinoma, embryonal carcinoma, yolk sac tumor, teratoma, and seminoma. The cause of these tumors are unknown, but changes in the genes of the germ cell can cause them to grow abnormally and lead to cancer. Signs and symptoms of germ cell tumor includes pain at the groin area, lumps in testicle, and undescended testicle where one or both testicles are dropped from the scrotum.
Next is the management and outcome for the germ cell tumor. On 14 November 2019, patients started chemotherapy VIP regime, which is a combination of 3 chemo drugs included cisplatin, etoposide, and ifosfamide. The chemotherapy drug administration is repeated every 21 days for 4 cycles. Patient was given pre-medication which are PO-aprepitant, IV granisteron, IV dexamethasone, and pre-cisplatin medication which are IV normosaline 500 ml with magnesium sulfate over 1 hour and IV mannitol 20% 250 ml over half an hour. This pre-medication is to reduce the side effect of chemotherapy such as nausea and vomiting. IV granisteron, IV dexamethasone, and pegylated filgrastim is given to the patient after chemotherapy is finished, also to reduce the side effect of chemo. Baseline CBC, DC, LFT, BUS, serum creatinine, 24-hour creatinine clearance, serum calcium, magnesium, phosphate, urine FEME are repeated after completing chemotherapy to check the serum and urine content. Also, the doctor ordered urine dipstick TDS to detect the presence of hemoglobin in urine. Patient need to watch out for allergic reaction toward the chemo. And the tumor lysis profile TLP blood investigation need to be taken TDS. Also, the patient is on strict IO charting. Management for the hyperkalemia. On 15 November 2019, patient serum potassium rose to 5.2 millimole per liter, and also on 18 November 2019, patient developed hyperkalemia which is 5.7 millimole per liter. The medication to treat the hyperkalemia was insulin chase, IV atropine 10 unit, IV dextrose 5%, 50 cc, and IV calcium gluconate 20%, 10 cc that is given to the patient. Doctor also prescribed oral calimate 10 mg TDS to prevent the hyperkalemia. Tumour lysis profile TLP blood investigation is taken TDS to monitor the electrolyte imbalance. Patient is on low potassium diet, and on 16 November 2019, the hyperkalemia is resolved. After that, management for the hypersensitivity is on 14 November 2019. On the first day of the chemotherapy, patient developed allergic reaction flushing around his neck and his face after 10 minutes receiving the IV etoposide. Chemotherapy need to withhold until the allergic reaction is stopped. IV hydrocortisone 100 mg and tablet Piriton 4 mg is given to the patient to treat the allergic. Patient allergic is resolved after 24 hours. Next is on 21st November 2019, patient having URTI, upper respiratory tract infection due to the low immune system. Patient complaining of runny nose, sore throat, and pain on swallowing. After that, the doctor prescribed IV augmentin 1.2 gram TDS. Doctor also advised the patient to always wear the surgical mask all the time to prevent the infection. Thank you.
Hi, my name is Mary Shakira binti Azapita. I will be presenting on the nursing care plan. The first nursing diagnosis is electrolyte imbalance hyperkalemia related to tumor lysis syndrome secondary to usage of cytotoxic drugs as evidenced by patient's potassium level of 5.7 mmol per liter. The goal is the patient will be able to display normal potassium level of 3.3 until 5.1 mmol per liter throughout hospitalization. The first nursing intervention is monitor the patient's heart rate and rhythm to be cautious about cardiac arrest. Second is assess the level of consciousness and neuromuscular function, including sensation, strength, and movement, as muscular paresthesia, weakness, and flaccid paralysis may happen. Third is educate patient about the role of potassium in body, what high levels of potassium mean, and the sign and symptoms, so the patient will be able to know when to report. The fourth is advise patient to avoid food high in potassium such as banana to reduce exogenous sources of potassium. Fifth is administer medication as ordered such as calimate powder 10 gram TDS to promote potassium excretion and lower blood level of potassium. Sixth is monitor laboratory results, especially serum potassium, to evaluate therapy needs and effectiveness. The evaluation is done. The patient is able to display potassium level of 4.7 mmol per liter, which is within normal range of 3.3 until 5.1 mmol per liter. The second nursing diagnosis is altered comfort nausea related to side effects of cytotoxic drugs as evidenced by patient reporting of feeling nausea during chemotherapy treatment. The goal is the patient will be verbalized of decreased nausea and no episodes of vomiting within 24 hours nursing intervention given and during chemotherapy treatment. The first nursing intervention is assess the duration, frequency, and nature of nausea and any aggravating and elevating factor to plan appropriate nursing intervention. Second, remove any visual stimuli and sources of odors from the patient's surrounding, which can cause the patient to feel nauseated. Third, advise patient to take deep, slow breathing when nauseated and to change position slowly, as rapid movement can result in chemoreceptor trigger zone stimulation and subsequent excitation of the vomiting center. Fourth, maintain fluid balance in patient. Sufficient hydration before chemotherapy has been shown to reduce the risk of nausea. Administer intravenous cytotoxic drugs slowly unless contraindicated to decrease stimulation of the vomiting center. Last, administer antiemetics as ordered such as IV dexamethasone at milligrams 30 minutes before chemotherapy to reduce the episodes of nausea. Evaluation is done. The patient verbalizes of occurs nausea and no episodes of vomiting within 24 hours nursing intervention given and during chemotherapy treatment.